2 rounds of terbinafine, and 1 round of itraconazole. Still has nails that look like that. So what are we going to do here? Are we going to give him terbinafine again for another 3 months? Are we going to KOH culture or clip the nail for PAS? Are we going to tell him that it's just toenail fungus and not to worry about it? Or are we going to say, oh, it looks like psoriasis, let's start him on a biologic? Somebody shout out the answer. What do you think? 1, 2, 3, or 4? Okay, I think I heard 2, and that's exactly right. We're gonna KOH culture or clip the nail, try to confirm the diagnosis. So, well, guess what though? Those clippings were negative. So now what are we gonna do? It still looks kind of like toenail fungus. What do you think next? Are we going to just give him terbinafine anyway because it looks like fungus? Are we gonna do a full skin exam, review of systems, avulse the fungal nails, or treat for nail psoriasis with methotrexate? What do you think? 1, 2, 3, or 4? Just shout it out. Number 2 again, okay. And I think that's a good idea. We are going to look at his skin. We want to look at other places where we might see psoriasis and other places that would give us clues. So here are his toes. Let's take a look at his hand. And that's right next to my resident's hand there. Can you see his hand? What do you think? Is that giving us a clue anywhere? You might have to go back to medical school and think about some of these things. Let's look closely at the hand. What do you think? Anybody know what that's called? Tripe palm. Wow, good job. Somebody is with it. Yes, tripe palm. And you start looking around in other places and you see other problems that are associated with things. So are his toes onychomycosis? Well, that's not what we're thinking about here. Anybody know what he has? I think somebody said base X. That's exactly right. Acrokeratosis paraneoplastica of base X. If you had just treated him for fungus, you would have missed it altogether. It's associated. It's a paraneoplastic problem, so it's associated with a malignancy, usually an upper respiratory malignancy. And the nail, actually, the nail and skin changes can occur before as the presenting feature, so before the malignancy is diagnosed. So you want to kind of keep it. It's very, very rare. It's not something you'll see very often, but you definitely don't want to miss it. And interestingly, the nail findings and skin findings can get better once the malignancy is treated. Okay, let's move on. Another case. This is a teenager who came in. She has this nail lesion. She thought it was fungus. She wanted it treated, and it happened after she was playing football game with her friends. About 2 months after that is when it started. So, and it's tender. Any ideas? What do you think? Let's take a look. Well, it looks like a wart. You're right. Let's see. So what are we going to do? Give her a course of terbinafine? Are we going to culture her nail for staph or strep? Are we going to x-ray her digit? Or are we going to tell her to cover it with an acrylic nail and just ignore it? What do you think? 1, 2, 3, or 4? Oops, I got those numbers mixed up, didn't I? X-ray the digit. Yes, that's exactly right. X-ray the digit. Okay, and what do we see? What do we see here? A subungual exostosis. Very good. That's exactly what it is. And you can't, and you want to know, you want to know that that's what it is because that's a bony growth. It's a subungual tumor that presses up on the nail bed, causes some discomfort, and you don't want to just cut into it if you don't know that it's bone, so for a biopsy. So knowing what it is important. Now, once you know what it is, you can confirm it. You can take off the nail and look, and they're pretty characteristic. They are a bony growth. They're actually composed of bone with a fibrocartilaginous cap, and they're tender, so that's a clue. They're tender. Children, young adults, we see them in older people too. Girls, for some reason, more than boys. Toenails more than fingers, although most of my pictures are finger. And surgical removal is good, although there is a recurrence rate, especially in younger children. This is another one. This one is pretty obvious. It is actually growing out from under the nail. Again, subungual exostosis. But sometimes they're subtle. This is a young college student, actually, who came in. You can barely see a little bit of white there, kind of onycholysis. It's very tender when she presses on it, and it peeks out from under the nail. So, if you see something like this, get an x-ray. You can be a hero and make the diagnosis. Don't just treat it as though it's a fungus. Okay, and there it is. If you're very comfortable and expert at nails, great. Otherwise, make the diagnosis and send it to somebody, but you can really help these patients a lot.